Great, yes.
All right. Well, thank you everyone for joining. This is Reese Garcia at Fight CRC. And today we have Laura Perry from Tulane University presenting with us. Today, Laura will be discussing psychosocial factors in cancer. And at the end of the webinar, we'll have time for questions. And if you have any additional follow-up questions, Laura's contact information is here on the main screen. So with that being said, I will hand it over to Laura to present on her work.
Great. All right. I think I have the right screen up.
Yep, looks good.
Let me see. Let me see if I can use my arrows to move. Whoop, there we go. Okay. All right. Good afternoon, everyone. Thank you, Reese, for the introduction. And thank you so much for inviting me to lead this webinar today and talk to you guys about psychosocial factors in cancer. And also, thank you for giving me the opportunity to talk to you guys a little bit about the research that I've been involved with also. I also just want to take a moment to thank everyone involved with the Fight Colorectal Cancer organization for so enthusiastically supporting my research. And especially I wanted to thank all of the members who volunteered to participate in my research. That's been really helpful and has allowed me to continue my research that I'm so passionate about. So thank you all. You guys have been super helpful. So the main goal of this presentation today is I wanted to introduce you guys to the field of psycho-oncology, for those of you who might be unfamiliar with that term. So I'm going to begin by discussing some of the common psychosocial issues faced by individuals with cancer. Then I'm going to go into an overview of palliative care and talk about some of the medical evidence for patient outcomes of palliative care. And then I'm going to end with presenting some of the recent results from my research program about patient perceptions of palliative care. So just as a brief introduction to myself, I am in my second year of a doctoral program in psychology at Tulane University, which is a university located in New Orleans, Louisiana. And my research is housed in the Psycho-Oncology Research Program, which is a research group that's devoted to conducting research on improving quality of life in cancer by anticipating, preventing, and alleviating the physical and emotional burden of cancer. So the first thing I wanted to do was to just introduce the term psycho-oncology for those of you who are unfamiliar with it. So psycho-oncology is the scientific field of study that's at the intersection of psychology and oncology. And it's a really widespread and interdisciplinary field. It's focused on how psychosocial factors, including thoughts, feelings, emotions, relationships, and culture can contribute to cancer outcomes. And also the field seeks to examine how the experience of living with cancer affects patients and their families in multiple domains of their life. Again, so it's a really broad and interdisciplinary field of study. Kind of just to exemplify this, I copied some of the main research priorities of my research program that are listed on our website onto this slide. So our research priorities range from studying palliative care, especially outcomes of palliative care and patient perceptions of palliative care. We also study patient education and empowerment, psychosocial determinants of quality of life and mental health in cancer, cancer disparities, smoking prevention and cessation, health psychology education and training for both students and established researchers in the field. And lastly, translational psychological science, which is basically a term that refers to using fundamental knowledge and ideas from the field of psychology, such as personality, emotion, and decision-making, to better understand cancer outcomes. So those are broadly some of the wide-ranging topics that we study in my research group. So among all of those topics, one of the topics that I've focused on myself during my graduate studies is psychosocial distress in cancer. Specifically, I've been interested in what types of factors or variables are related to distress. And I've also been interested in what types of interventions might help relieve feelings of distress in patients with cancer. So I'm going to talk to you a little bit about the factors related to distress and also what people are doing about distress in oncology care. Okay, so what is distress in cancer? Well, the National Comprehensive Cancer Network defines distress as a multifactorial, unpleasant emotional experience of a psychological, social, and/or spiritual nature that may interfere with the ability to cope effectively with cancer, its physical symptoms, and its treatment. Also, within that definition, the NCCN kind of describes distress as extending along a continuum. And this continuum ranges from kind of normal feelings of vulnerability, sadness, and fears to problems that could actually become pretty clinically significant and disabling for the patient. And these could include symptoms of depression, anxiety, panic, social isolation, and even existential and spiritual crisis. And one of the overarching statistics about distress in cancer is that about 30 to 40% of patients who have cancer will experience some kind of psychosocial distress at some point during their illness. So it's really a very common issue in cancer that is significant and needs to be addressed during oncology care. So two of the most common types of distress in cancer are feelings of depression and feelings of anxiety. So depression can be described as excessive feelings of sadness, despair, hopelessness, social isolation, and even loss of interest in activities or loss of pleasure in activities that they used to obtain pleasure from. And symptoms of depression tend to occur in about 16 to 22% of patients with cancer. And this rate is about 3 times higher than the rate of depression in the general population. So people with cancer are already at an increased risk of distress compared to people who don't have cancer. Another common type of distress is anxiety. And anxiety can be described as excessive feelings of worry, fear, or nervousness about a perceived threat or a perceived danger. So in the context of cancer, the perceived threat or the perceived danger could be an impending test imaging result, or an impending test result or an imaging result. Patients could experience anxiety about upcoming treatments. Patients could experience anxiety about the potential of their disease progressing. And then in the context of long-term cancer survivors, a lot of survivors tend to experience anxiety about disease recurrence. And one of the main characteristics of anxiety is that a person will tend to try to escape or avoid the anxiety-provoking stimulus. This is really important because in the context of cancer, this could have a significant impact on treatment effectiveness. So for example, if a patient is experiencing anxiety about disease progression or about disease recurrence, this could actually backfire on them, and they could actually start exhibiting avoidance behavior and begin avoiding regular checkups with their healthcare provider or even their oncologist. As well, if patients are experiencing anxiety about upcoming treatments, they may even avoid important treatment sessions. So as you can see, anxiety and depression can have a significant impact on treatment effectiveness in this way. So this slide, I kind of just was trying to provide a list of some of the major risk factors of distress in patients with cancer. I just want to stress that this is in no way an exhaustive list of everything that is related to the experience of distress. But these are some of the factors that have come up in our own work and in others' research that has influenced our research. So for example, individuals of lower socioeconomic status, including individuals with less education or a lower annual income, may be at an increased risk of distress. Also, one of the most important predictors of both physical and psychosocial outcomes is actually social support. So this is just how much support a person has from their family and their friends. So after being diagnosed with a serious illness such as cancer, you can imagine that someone who has less social support might be at an increased risk of distress. Additionally, research has identified women and younger individuals as being more likely to experience distress compared to men and older individuals. So things like gender and age are also important factors in whether a person is at higher risk for experiencing distress. Additionally, individuals who had a pre-existing psychiatric diagnosis, such as depression or anxiety, are more likely to experience distress following a cancer diagnosis. And people with certain personality dispositions may also be more likely to experience distress. For example, a personality trait called neuroticism is pretty highly studied in the field of psychology as well as psycho-oncology and health psychology. And neuroticism just refers to an individual's tendency to experience general emotional instability and feelings of sadness or worry. A large body of research has actually linked the personality trait or personality disposition of neuroticism to an increased risk of psychosocial distress. So people who are higher on the neuroticism trait may be more likely to experience distress than people who are lower on the neuroticism trait. And then the last 3 bullet points I have on this slide are actually factors that are related to characteristics of the illness itself instead of to the individual. So for example, Individuals with cancers that are typically more aggressive, such as lung cancer or pancreatic cancer, typically tend to experience more distress than individuals with less aggressive cancers. As well, individuals with more advanced cancer or individuals with cancers that have metastasized beyond the original location may also be at an increased risk for distress. And finally, individuals who experience more severe symptoms or side effects as a result of their illness or their treatment tend to experience more psychosocial distress as well. So to summarize, there are a lot of factors that could put an individual at either an increased or a decreased risk of distress. I'm sure I haven't covered all of the possible factors on this slide, but I just wanted to expose you guys to some of the factors that have come up in my study of distress so far. So in addition to the increased emotional burden that experiencing distress will inevitably put on an individual, the experience of distress can also have adverse effects on other aspects of the patient's functioning. So for example, just as increased symptom burden can contribute to a patient's experience of distress, the experience of distress can actually feed back and also lead to poorer physical quality of life and more severe symptoms for that individual. As well, people who are distressed tend to have more trouble adhering to or complying with advanced medical treatments compared to individuals who are less distressed. So an individual who's more distressed might adhere to a chemotherapy regimen less strictly than an individual who's lower on distress, for example. As well, individuals who are distressed may be more likely to be admitted to the hospital. And once they are admitted to the hospital, distressed individuals tend to stay there for longer compared to non-distressed individuals. And furthermore, being under psychosocial distress can be extremely mentally taxing for any individual. So a patient who is distressed may actually have a harder time making important decisions about their medical care. And lastly, if a patient is distressed, this can also lead to their primary caregiver feeling more psychosocial burden and distress as well. So all of these consequences of psychosocial distress, as you can see, may actually lead to poorer physical outcomes, in addition to the significant emotional burden that distress inherently poses for a patient. So as you can guess, addressing distress in a clinical context is really important for these patients. So acknowledging that the experience of distress is a significant issue for individuals with cancer that can affect all aspects of their quality of life, including their emotional quality of life, their physical quality of life, and even their social quality of life. What are healthcare professionals doing to address distress? Well, in the early 2000s, one of the major clinical oncology organizations of Canada actually declared distress as the 6th vital sign in cancer care. And this movement came shortly after they made pain the 5th vital sign. So vital signs are basically healthcare measures that are routinely routinely assessed during doctor's visits and oncology visits. And the traditional vital signs that are often assessed are biomedical or physiological in nature. So these include checking your blood pressure, checking your temperature, checking your pulse or heart rate, and checking your respiratory rate. So those are the kind of 4 traditional biomedical vital signs that are assessed during doctor's visits. However, in the late 1990s, professionals in cancer began to acknowledge that pain should also be routinely assessed along with these biomedical markers. And this was really significant because pain is a healthcare measure that needs to be self-reported by the patient themselves. So this movement towards assessing pain kind of symbolized medical professionals beginning to adopt a whole patient or a patient-centered model of care that began to put more trust on the patient themselves as a valuable source of their functioning, instead of solely relying on these 4 historical biomedical vital signs for assessing an individual's physical functioning. And making pain the 5th vital sign kind of paves the way of putting an increasing importance on psychosocial issues, as well as self-reports of distress. So now screening for distress is actually a routine practice in the United States across cancer centers, and it's recommended by multiple professional organizations, including the American Society for Clinical Oncology and the National Comprehensive Cancer Network. And this routine screening of distress is basically just composed of giving a brief 1-item question to the patient to fill out. And the question is called the distress thermometer. And it just asks patients to rate from 0 to 10 how distressed they've been feeling recently. So closely monitoring distress and recording it in a patient's healthcare record has allowed healthcare providers to recognize when distress may be becoming a significant issue for patients, and it's allowed providers to help get these patients the help they need in a more timely fashion compared to before this system was in place. So in addition to routinely screening for distress to identify significant cases of distress in patients, another area of oncology care and practice that's been addressing psychosocial distress in cancer patients is palliative care. And palliative care is another one of the main research priorities of my research group here at Tulane University. And especially we've been examining how palliative care may benefit various patient outcomes. And also we've been examining patient attitudes and perceptions surrounding palliative care. So the next section of this talk, I wanted to briefly discuss what palliative care is, talk a little bit about some of the medical evidence supporting palliative care, and then present some of my research team's recent research findings about patient perceptions surrounding palliative care. So what is palliative care? The National Institute of Cancer defines palliative care as care given to improve the quality of life of patients who have a serious or life-threatening illness, such as cancer. And some of the defining characteristics of palliative care is that it can be provided at any point in the illness course, ideally as early as is needed. So evidence actually suggests that providing it as early as possible will provide the best benefits for patients. So a individual can actually seek palliative care right at diagnosis if they have significant symptoms or distress that they'd like to be better addressed. Another characteristic of palliative care is that it can be provided at the same time as other treatments that are aiming to cure the illness, such as chemotherapy or radiation or surgery. A popular misconception is that if you would like to, if you're a patient and you would like to pursue palliative care services, you have to give up your other treatments that are aiming to cure your illness, and that's actually not true. You can receive both palliative care and other cancer treatments at the same time. And palliative care is really appropriate for any patient with any symptom, concern, or problem that they would like to be better addressed, or just for any patient with a serious diagnosis. And lastly, families and caregivers are welcome in palliative care if they feel like they would benefit from some additional support as well. So there are two primary goals of palliative care. The first one is really focusing on whatever physical symptoms are bothering a patient and helping to manage those symptoms. So symptoms could include pain, fatigue, nausea, trouble breathing, anything that's either a symptom of their illness or a side effect of whatever treatment they're receiving. And then another primary goal of palliative care is to provide psychosocial support and help patients cope with any distressing emotional symptoms they may be experiencing as a result of their cancer diagnosis. And then some secondary goals of palliative care include helping the patient and their family to understand the illness and maybe get a better understanding of their prognosis, or just answer any questions they may have about their illness. Helping patients and families make some of the really difficult treatment decisions that might occur in the course of their illness. For example, helping patients decide whether or not to continue treatments that may or may not be working. And lastly, palliative care also seeks to help patients discuss advanced care planning if they choose to discuss those issues as well. So the two primary goals are managing bothersome symptoms and providing coping support with other secondary goals listed below. So does palliative care work? Well, there's been a growing body of scientific evidence showing the beneficial effects of palliative care on various cancer patient outcomes. And the most compelling and consistent effects in this body of literature have been shown for physical quality of life or symptom burden, as well as depression symptoms. So, for example, this graph shows results from a seminal study of palliative care and cancer called the Early Palliative Care Study. And in this study, patients were randomized to either receive palliative care intervention that included monthly consultations with a palliative care team, or to a control group where the patients received standard oncology care practices at that time. And this graph is showing the percentage of patients who saw an improvement in their physical quality of life at 3 months after the start of the survey. So palliative care group is on the left and the control group is on the right. And as you can see, about 58% of those who were randomized to the palliative care group saw improvements in their physical symptoms, such as pain, nausea, or fatigue, compared to just 42% of patients in the no palliative care group who saw an improvement in their physical symptoms. So there is compelling evidence that palliative care does improve physical quality of life. In addition to physical symptoms, the study also found that at 3 months after the start of the study, only about 16% of those in the palliative care group experienced significant depression symptoms, whereas about 38% of participants in the control group had symptoms of depression. And lastly, one of the most significant findings of this study was that individuals assigned to the palliative care group actually lived on average about 2.5 to 3 months longer than individuals who were assigned to the control group. And this is a really significant finding of the early palliative care study because it kind of indicated that better quality of life, which is achieved through palliative care, and quantity of life may not be incompatible goals in cancer care, which is something that both patients, caregivers, and doctors often think, that there's this trade-off between quality and quantity of life. And from these findings, people in the palliative care group certainly didn't live less. They lived at least the same amount of time as the control group, if not longer. So despite high quality medical evidence that indicates the benefits of palliative care, unfortunately, it's often underutilized by patients. So it's either delayed to the final 2 months of life, or it's often never used at all by patients. And this could be due to some of the emotions and misconceptions that people have when they think about palliative care. So for example, many people may view palliative care as scary, possibly because of the difficult topics that are often discussed during palliative care, despite the evidence that's shown that it's actually helped to decrease emotional distress in patients who do choose to seek out palliative care. Also, about 80% of the general public reports not knowing what palliative care is. And people often misconstrue it as being equivalent to hospice care or end-of-life care or giving up. And these are actually not synonymous with palliative care. So hypothesizing that fear and misconceptions of palliative care is really what's driving underutilization of palliative care. Our research team here at Tulane University has begun to develop a research program that seeks to educate patients, caregivers, clinicians, and the public about palliative care, as well as about its evidence base. So in an initial study called Project Empower, we examined whether educating patients about the beneficial results from the early palliative care study on depression, quality of life, and survival improved patient preferences for palliative care. So in that study, 589 patients with cancer participated in an online experiment. They were randomly assigned to one of two groups. The first group was the intervention group, where participants received a summary of the recent research findings from the early palliative care study, showing the benefits of palliative care for physical quality of life, depression, symptoms, and survival. And then the other group was the control group, where participants received no information at all about palliative care. And participants completed a measure of preferences for palliative care before and after the intervention. And this measure of preferences for palliative care included three main domains. So participants reported on how scared they were of palliative care. They reported on how much they thought palliative care would be effective for their physical and emotional symptoms, and they reported on how willing they were to seek out palliative care services. And the main findings from Project Empower were that 75% of the participants in the intervention group who received a summary of the medical evidence of palliative care actually demonstrated an increase in preferences for palliative care. So these findings indicate that patients who are informed about palliative care and its evidence base may actually be less scared of palliative care, and they may be more willing to pursue palliative care than uninformed patients. And it also just points to the importance of psychoeducation in medical contexts, and how informing patients in an empathetic way might be able to help patients make difficult healthcare decisions, such as deciding whether or not to pursue palliative care services. And that is everything I had scheduled to talk about, but if anyone has any comments or questions, please let me know. Thank you so much.
Thank you, Laura. That was an awesome presentation and very informative. I wanted to ask you before I open it up to questions from those listening. Mm-hmm. You said that the Project Empower also targets caregivers and physicians, educating that population. Has anything come out of the research yet in terms of educating physicians, and if that's been beneficial or maybe more beneficial than educating the patient?
So our research program actually hasn't targeted physicians or caregivers yet, although that is kind of on the horizons of our research program. But right now, that initial study, Project Empower, that was published in Health Psychology, just focused on patients. I know there's been some research looking at educating physicians and med students, and it's helped improve their knowledge of palliative care, and I would assume it's helped improve their preferences and attitudes towards palliative care also. But I can look more into that too, and get back in touch with you guys if you'd like.
Sure, that'd be awesome. Do you know if Project Empower, once it's kind of reached its impact, is it going to have any? Do you foresee any integration into other oncology programs long term?
So right now we're just looking at patient preferences, and we're actually kind of building on Project Empower. We have another study called Project Empower 2.0, but we haven't finished data collection or anything for that phase yet. But we're looking at kind of scaling up the what we call the psychoeducational intervention, but that's basically just the educational component for patients of what palliative care is. We're looking at scaling that up and making it into a video kind of education platform, and looking at how that will affect patient preferences as well. And then kind of the third aim of that study is possibly looking at it, piloting it in like a small cancer center locally, but we haven't started any of those phases yet of research.
Awesome. That sounds great. Does anyone else on the call right now have any questions for Laura? Okay, well, I just have one more then. What what would you say some of the most beneficial palliative care approaches or practices are that specifically target distress, in your opinion?
Yeah, that's a really good question. So one of the issues in the palliative care literature right now is that there are like multiple teams across the country that are implementing palliative care approaches, but they're not necessarily like standardized approaches yet, if that makes sense. So kind of like every team approaches palliative care a little bit differently. But mainly for distress, I think that the primary aim of actually addressing distress and trying to help patients cope with distress and their families cope with distress, maybe giving them different coping resources, I would assume that's what's driving the decrease in depression symptoms.
I see.
Did I answer your question adequately?
That was insightful. Thank you. And we have another question.
You're welcome.
Actually, we have two more questions. So do you know if insurance pays for palliative care visits, / is it a billable service?
So that's a great question. I would assume it's a billable service. Our team doesn't actually provide it clinically, so I would assume that that varies based on location. But like I know the VA, at least locally in New Orleans, is providing some palliative care services that would, be covered by insurance. So yeah, I would assume that would vary, but yeah, we're not providing it ourselves, so I don't really know the ins and outs of that myself.
Well, great, thank you. And then I'm gonna unmute you, Lyra. One of our advocates would like to make a comment.
Of course, yeah, that'd be great.
Can you hear me?
Yes.
I can.
Okay. I just wanted to speak to my own experience with this with my son from Massachusetts General Hospital. They did provide palliative care. This included a social worker that would visit with him during therapy or treatment rather. And I even had access to her and twice talked to her about my own distress, and she was extremely helpful. The other thing that was very helpful was the palliative care. She was a PhD. I don't know if psychology, medical, or what. She was the one that sat down with John at the end of his life. Evidently, they had already discussed it, but she came into the room and she said, "John, is this the time we need to have that talk?" And it took the burden off of the rest of us. And I really appreciated having that. And I assume it was part of our bill. I don't know though.
Right. Yeah. Thank you so much for sharing that experience. That's really insightful. Yeah. I mean, that's one of the things that palliative care specialists do best is that they're not afraid to address those difficult issues, that you just described. So thank you for sharing your experience.
So then on that note, Laura, what suggestions do you have for advocates or caregivers or family members that might be listening to proceed with looking at palliative care options?
That's I would suggest talking to your oncologist or talking to your primary healthcare provider. My sense is that what types of palliative care resources are available, it really depends on your specific location. Like for example, MGH is, in Boston is one of the leading areas of palliative care, but not every city, is as equipped with palliative care services as that. But I would assume that your oncology care team would know what's available in your area. I think that would be a good starting place.
Well, great. Just to check one more time, see if there were any more questions. And if not, thank you so much, Laura. This was very informative, and I think this will be very educational for our advocates and anyone watching.
Of course. Thank you so much for inviting me again.
Of course. I hope you have a good day, and I'll be in contact soon.
Thank you. Great. Thanks so much, everyone else, for tuning in.
Sounds great. Have a good day.
And you too. I was just going to say, I can get back to you about that question about the evidence base for educating physicians and caregivers.
Oh, that would be great.
Yeah.
Awesome. Well, thank you so much, and have a good one.
Thanks. You too, Ray.
Bye.